very important. There is, I just want to club it. We do 6 months of extensive 5 cycles of chemotherapy, and then afterwards 2 years of maintenance therapy. This all depends on the protocol which your institute is following. So as we follow BFM induction to 2002 protocol, so we give 2.5 years of treatment. These are the drugs that we use, that you all know. Do's and don'ts: do refer patient at the slightest suspicion, as early diagnosis improves the outcome. I have already explained what are the clues and how to diagnose early. Do not give steroid prior to referral. Please, this is the must thing which you should remember. Do not give steroid. Please refer the child, the pediatric oncologist, hematologist, they will do the marrow. If you are in medical college, you can only do the marrow and then give steroid. Do not transfuse unless the patient is severely anemic, because it can change the picture. I mean, even if the child is in need CCF, give transfusion. I mean, there is no contraindication for doing it. You can still do a marrow and biopsy. Do start antibiotic if there is fever, because they are immunocompromised patient. Okay, so you have to start antibiotic on an early basis. When to refer? Whenever you have a suspicion, please refer it. There is no delay. AML is another thing. It is also, I mean, poor prognostic leukemia. The type, I don't want to deal with that, but I would just want to focus that AML is a bad prognostic, and you have to have early suspicion and referral whenever you have a case of AML. Last thing is APML is another entity. Very good, cancer if you diagnose early. We have 8 cases of APML and we did not see one single death. Why? Because APML has a very good survival, not more than 80, now it is more than 90-95% in standard risk ALL. They present with pancytopenia. If you don't diagnose early, they will present with that DIC wala picture which you see in your textbook. So if you don't want to go that, just see the pancytopenia. If bleeding manifestations are more, they look like pancytopenia on an early thing. But once you do a marrow and if you do translocation 1570, you get to know that this is APML. Immediately start with tetra-ATO. They don't even require chemotherapy. We don't even do, we just use targeted therapy in standard risk, that is tetra-ATO, and we have seen beautiful response. So the key message is, please diagnose these cases early, refer them early, and have a very high degree of suspicion. And if one message if you want to take, whenever you have a child which you are not understanding and diagnosis is not clear, just see the serial CBC 4-5C, write in your notebook, see the serial count, platelet count, lymphocyte percentage, and then you can get the clue. Thank you very much for this opportunity. Thank you. Any questions?
Thank you, Dr. Shweta, for this great talk. And I would completely agree with her on one thing, because we are a referral center. Please send 2 EDTAs and 2 heparin always, along with all bone marrows, on the slightest suspicion that it will turn out to be acute leukemia, because you need 1 EDTA for flow cytometry, 1 EDTA for your PCRs and NGS, 1 heparin for karyotyping, and 1 heparin for FISH. So if required, at least there will be no shortage of samples, and usually these are different sub-departments. So less sharing of sample leads to less confusion. We all can have our each vial. So please go ahead.
First of all, I would like to thank Professor B.R. Srivastava sir inviting me as chairperson for such wonderful CME that really give the impact in the mind of the clinicians, that none of the patient of the anemia to be overlooked, unless until once you decide, once try to look the peripheral smear. Always pay the attention to the peripheral smear. When we were the house physician, we used to prepare it and we used to see personally. One. Number 2, if very nice message given by the madam, and now I am inviting the learned person, good teacher from my own alma mater, that is MGM Medical College, Dr. Akshay Lakhoti. I am very well aware about his name, fame, and working, and lot of credits to the in his academic field. Now, Dr. Akshay Lakhoti, please elaborate the common, one of the common malignancy, the journey of CML we have seen from Myleron to the imatinib, now up to the BMT that he is doing at Indore. Dr. Lahoti, please.
Thank you, sir. Thank you so much, sir, for the kind introduction, sir. And this talk I have made very basic because we have many students with us, and with this we will be able to understand, most of us will be able to understand what is CML and how do we treat them clinically. So this topic was assigned and this made me understand it more. Thank you first of all the organizers, Dr. Vijay and Dr. Anil, and the entire team for organizing this fantastic CME. So coming on to CML, so this is the other end of spectrum. What we have understood from the previous talk, that was acute leukemias, which is quite acute. And those people, those patients do not give us much time. So it is being diagnosed within a month. You need to treat them within a month. Otherwise, the patient has poor prognosis. On the other end of the spectrum, we have these chronic leukemias where you have plenty of time. So we are not in a hurry, but yes, we need to diagnose these patients so that we can treat them also. But this is not life-threatening for almost 6 months down the line once the patient is diagnosed. But those acute leukemias are life-threatening unless they are treated very early. So seeing a CML patient in the clinic do not give you any goosebumps. It makes your life and the patient's life at peace. On the other hand, the acute leukemias makes the life miserable for both. So this is a chronic myeloproliferative disorder which is marked by an excess of myeloid precursors in the blood and the marrow. And yes, we will be discussing this, that there is a molecular level which is known as BCR-ABL1 fusion gene. So approximate, this is a data which has been taken from the multiple papers. So this is an approximate data that we have around 15 to 20,000 new cases every year. We have 4 to 6,000 deaths every year as compared to US, which is lesser. So in India we have a problem of diagnosis, we have the problem of compliance, we have the problem of more of blast crisis because of the later presentation. So we have more deaths, and somewhere around 1.5 to 2 lakhs prevalence of CML patient we have in India. So coming on to the era which was pre-TKI era, this disease was as fulminant as acute leukemias, and this was rapidly progressive, often a fatal disease, giving an expected life of around 3 to 5 years to most of our patients. So 3 to 5 years median survival for most CML patients before TKI were introduced. What is TKI? We will discuss again. This was the only hope during those time where allogenic transplant was considered as the only cure for most of our chronic myeloid leukemia patients. But again, the allogenic transplant is a high risk procedure. It carries significant morbidity, GVHD, transplant related mortality. Therefore, but this was the only cure hope for the younger fit patients. This was applicable in 1980s and 90s, the only realistic chance for long-term disease-free survival. But there were limitations because now the transplant thing has also evolved over time. We have many newer drugs for the GVHD prevention, for the CMV prevention and the treatment. So the complication of transplants are taken care more efficiently now, which were not taken before. So there were high transplant related complications including infections, damage, GVHD. There was strict eligibility criteria because we were not able to take older patients. So only younger fit patients were applicable or eligible for bone marrow transplant in 80s and 90s. And limited availability, again because of the non-viable candidates, leaving most without a curative option. Now the TKI revolution. So when we understand that the patient only could live around 3 to 5 years, what TKI has done, and what is TKI? So there is a discovery of this Philadelphia chromosome. This is a molecular driver of CML, and this discovery made the research from broad spectrum cytotoxic therapies toward the highly selective molecular targets. Peter Nowell and David Hungerford were two scientists and who were the first to ever find any chromosome abnormality linked to any human cancer. And this chromosomal translocation made a BCR-ABL fusion gene. To our surprise, to an everybody's surprise, sir, none of the scientists for the CML discovery and treatment have ever received a Nobel Prize. So this is unfortunate. So nobody has received any Nobel Prize for this discovery. But yes, this is a molecule, this is a gene which transforms this BCR-ABL1 translocation into a gene which basically activates. So it has a spontaneous activation which causes this tyrosine kinase activation, and thereby there is a downstream pathway which causes the more and more of cancer cells to be produced. So this tyrosine kinase activity, मतलब एक ATP कहीं से produce हो रहा है, so this tyrosine kinase activation has to be diminished. So now we have these tyrosine kinase inhibitors. So these are TKIs. Imatinib was the first breakthrough TKI. So when you target this tyrosine kinase activation, so thereby you are killing all those. So basically you are preventing them cells to growth, and thereby there is an auto-apoptosis of these cells. So thereby you are killing all the CML cells. So this was the regulatory milestone, FDA approved in record time, and it has achieved a cytogenetic and molecular responses which were not attained previously. So you have a molecular target discovered, you have a molecular target inhibitor discovered, and thereby you have made those life to cross as more as 10 years, which has exceeded more than 80% of the population. So with a single drug which can be taken as a pill, 80% or more of the people can survive for more than 10 years with a single imatinib drug, which is a dramatic improvement for pre-TKI era. So we are targeting the root cause, and yes, this has dramatically improved the survival, and this discovery has led to the formation of second and third generation TKIs also. So these are a broader BCR-ABL mutation coverage. So when we have a first generation, we will have a second generation, we will have a third generation, so that we can have more efficient drugs and we can cover more of these targetable enzymes. So thereby we have nilotinib, dasatinib, bosutinib, ponatinib. So many drug options we have for our CML patients now. And this is a fantastic guideline which is available to everybody free, and this is a European Leukemia Net recommendation for CML which tells us how to treat, how to monitor, and how to make these life more better with lot of recommendations which can be easily accessible and easily applicable also. So this is timeline of progress. In 1960 there was a discovery of PH chromosome. 80s and 90s was the prime era where these allogenic transplants were being practiced. 2001 Glivec, that is imatinib, became approved, and then 6 to 12 we have second, third generation TKIs, and now between 2021 and 25 we have another target which is known as asciminib. So with the TKIs most of their life has become better, but there are few patients who develop this TKI resistance too. So what to do for these patients? So we have now a new drug which is known as asciminib, which targets a next enzyme. So it is a novel inhibitor. So it is targeting the ABL myristoyl pocket, so which is different from the TKI. So if any patient has a TKI mutation, so these asciminib can be given to those patients very easily, and this can treat the remaining patients who are not responding to TKIs. So this is a new point of attack which has been told that it do not attack the ATP site, it binds to the myristoyl pocket and thereby inhibit it. This has shown the promising efficacy. So it is more efficacious than TKIs in the phase 3 trial, where it has been compared with lot of other TKIs, and it has shown that it has achieved a better major molecular responses as compared to the first, third, second or third generation TKIs. It has a good safety profile too as compared to the other TKIs, and it can be used in the first line, second line, and also there are emerging researches for the pediatric CML too. Now coming on to the other aspects of the CML part, where there is a revolving role of stem cell transplant. So when you fail asciminib, when you fail TKIs, still there are few patients who can undergo this allogenic transplant because there is no other option left for these patients. So now where allogenic transplant was given to the majority, it is now only restricted for the minority of the patients who fail the other drugs or who transform into your accelerated or the blast crisis. So now CML is not a fulminant disease, but it is a chronic disease. So you need to take care of so many things in a patient because these are on sustained therapy for many years or throughout their life. So you need to monitor their side effects. Comorbidities के हिसाब से we give the TKIs, whether there is any diabetes, heart disease, dyslipidemias, pulmonary disease. So when you have more options, you can take care of all the comorbidities and you can give them individualized TKIs. So we have now patient-centered goals where quality of life becomes more important along with keeping the disease under remission. When to stop TKIs? So now there is a provision to stopping TKIs also. So when you have achieved a major molecular responses for at least 2 years, in few patients you can give a chance of stopping their drug. So probably you are curing this disease in 3 years with more advanced treatments, and around 40 to 50% patients can be advised to stop their treatment after 2 or 3 years of therapy. Family planning and fertility considerations has to be taken care. So most of the male patients who are suffering from CML and are on a TKIs, they can be advised to continue TKI and they can conceive or become a parent. For females, obviously we need to stop these TKIs before conception and during the first or second trimester. There are many papers and many suggestions which suggest that in the second and third generation these TKIs can be resumed if the patient is not doing well with your interferon or hydroxyureas. So yes, you need to manage this chronic condition. It is not a death sentence anymore. And the future is novel combinations, SMA, personalized monitoring with more NGS sequencing, ultra-sensitive MRD assays, which give you more precise response assessment. And this is something which is future. ELN guidelines we need all to check. They are continuously updated. And this is something beyond imagination for when you think of any leukemia or any cancer, that you have made the life of these patients from less than 5 years to as long as normal with the treatment which is easily manageable on the OPD basis. So key takeaways: you had a transplant era, it was limited by high risk and strict eligibility. There was a TKI revolution, you have now an asciminib era, and now we need to take care of the long term management, TFR and quality of life for all our patients who are living well with CML. So the journey of CML stands as one of the most modern medicine's most powerful testament to the impact of scientific discovery, perseverance and precision. With this, I would like to thank you for your patient hearing and the organizers for giving me the opportunity.
Practicing in the USA, and he has written a very beautiful book which is known as The Emperor of All Maladies, in which he has focused on the how cancer developed in the human body, and like it's a very beautiful iconic book. I think all medicos should read it, and in that he has made a very beautiful observation about the scientists who discovered Gleevec or imatinib. That scientist, he said that I am actually responsible for increasing the prevalence of CML in the society. And that was a funny remark, because by increasing the prevalence, he actually meant that the survival has increased so much that now we are having so many more living patients of CML. So really hats off to your presentation. It was very erudite, very clear and very impactful. Thank you so much.
Thank you so much, Dr. Lahoti, for excellent presentation and giving the clear-cut view that in case of CML, with advancement in the chemotherapy, we can increase the survival up to a decade and rather more than that. And now, if audience have any more questions, Dr. Lahoti will be happy to reply.
So, if a patient get pregnant over imatinib, so what is your view?
Ma'am, at that moment we need to stop the drug and then probably we need to continue it only if it is a very precious pregnancy. Obviously it is advisable that you need to discontinue your TKS before conception.
Yeah.
So if it is a pre-shift pregnancy, we tend to continue it. Sir, otherwise we give them the option of abortion also if at all we can.
There are many pregnancies over the imatinib, and there are some congenital abnormalities have been
Yes,
reported.
sir.
So the family should be aware if they are. So we should advise it in early when you are starting. You should not get pregnant. So prevention will be better. If it's early, you should stop it. If it's late in the pregnancy, then the family's decision whether they want to continue. There are normal babies, but there is some chances of abnormal. So there is a big series has been published, but there is a risk of anomalies are there.
Sir, actually, patients को usually amenorrhea रहता ही है just because of chemotherapy and other things. तो सर उनको पता ही late चलता है usually 6 weeks
They
या.
should not have amenorrhea with imatinib. So if they have amenorrhea, check the pregnancy.
Okay.
And ma'am, it is much safer, although it is not recommended, but you consider it safe in the second and third trimesters now. We have a discussion with the international people also, sir, few months back for a patient. And their criteria was if the patient is not responding to deferral. So for your question, obviously we need to stop. But if the patient has progressed during the pregnancy in the second and third trimester, we tend to challenge the TKIs again during pregnancy again.
Okay. Thank you.
एक छोटा सा क्वेश्चन है, in how many cases of leukemia, CML, without splenomegaly?
So very few, but it is not a criteria that is if splenomegaly is not there, you cannot find CML. We have very few patients, they do present to us with high WBC counts also. We have few patients who has only presented with 30 lakhs of platelet count. The WBC was normal and that lady got found out to have CML.
Yes.
So yes, it is not clear cut, but yes.
Yes.
Is there, is there any association? I had read somewhere that there is an association of TKIs with diabetes, new onset diabetes. Probably, TKIs probably increase the risk of developing diabetes, but they haven't really proved its association. What is your take on that?
Ma'am, we generally counsel for the diabetic patient, we tend to monitor when we are starting nilotinib. So for the nilotinib single specific TKI, we generally counsel them not to use, so we give preference of dasatinib if we are using second generation TKI in the patients who are already having diabetes or any cardiac comorbidities. So it generally precipitates or it increases the threshold for diabetic populations.
One more thing, because in ये मेरा खुद का पर्सनल एक्सपीरियंस है, कुछ केस ऐसे देखे हैं मैंने. The infection is very problem in these patients. Okay, number one. Number two, in the last week, I had one patient. Her count was about 40,000, 50,000 WBC, presented with pyrexia. Okay. I sent for peripheral smear examination. One of my colleagues are here. The peripheral smear was non-conclusive, but at one another place, then it turned out to be some blast cells. So here, in presence of infection, it is very difficult to comment whether it is a leukemia reaction or early case of CML. What is your opinion? How to approach in such cases?
So
because that patient develop further, there is increased hemostasis, dehydration, pyrexia because of fever. Then patient develop the multiple microinfarcts and presentation was with a like a encephalopathy and CSF was normal.
Sir, here, although we have Dr. Ankit as an expert over here, but yes, basophils is something which is very peculiar for CML, sir. If you have basophilia, you tend to rule out the leukemioid reaction and then you concentrate more on CML. Plus, a blast cannot be missed. If at all it is a leukemioid reaction also, nobody can miss the blast in the peripheral smear. So somewhere there is a problem with the smear observation, sir.
Also, one point I want to make highlight here. So if you have infection and you are saying that there is leukemioid reaction could be there, so my point is you treat them with antibiotics in spite of giving adequate antibiotics. If the counts are still going up, no harm in sending one fish for BCR-ABL just to rule out the things. Just to complete the panel, you send one fish for BCR-ABL, turn out to be positive, it's clear-cut CML. And I have one question to Dr. Akshay. So, in how many cases you are seeing this TKI-related toxicity in terms of hematological toxicity? Because recently I have one patient, young lady, and diagnosed to have CML. As mentioned by sir, she had no spleen, nothing. The peripheral smear suggestive of CML, we sent fish for PCR-ABL, turned out to be positive, started on imatinib. But with the first dose of imatinib itself, she started having hematological toxicity. So what is your way to whether you want to change it, whether you want to reduce the dose or you want to give alternate day, what will you do that in such situation?
So it is a problematic situation and it is not very uncommon. What we have practiced is either we reduce the dose of imatinib. Secondly, if at all they do not get over with the reduction of the dose, also we tend to switch the TKI. But once the patient has the sensitivity to imatinib, there are more likely chances they will be sensitive to nilotinib or dasatinib also. But few of our patients have survived with nilotinib, even they were sensitive on imatinib. So changing TKI and reducing the dose is only the two ways what we can practice.
So taking this pancytopenia is not uncommon. Sometimes you give a hydroxyurea along with the TKI, so don't do that. And as soon as your blood counts are below 1 lakh, you stop hydroxyurea and start the TKIs. So give us some degree of this thing to cut down. And call them weekly. For the first few weeks, at least 2 weeks or weekly, you should call them. And giving a break in between to recover is an answer. Some people may not recover. I mean, they will have a pancytopenia. Eventually, they have a bad disease and may progress to the. So you should be worried about. Should do a close monitoring with the peripheral smear, BCR-ABL, just to make sure they're not suddenly going to the blast crisis.
That particular patient actually recovered with a break of 1 week.
Yeah.
So
mostly they will recover with this. Well, I think we have to stop it. So.
Thank you. So next, I will request Dr. Binay Bora for next speech. He is from Vishesh Jupiter Hospital, Indore. His work is on lymphoma and myeloma, and a specialist in BMT.
Thank you, organizers. Thank you, B.R. Srivastava sir. Thank you, Gunjan madam. My friends, Dr. Anil and Dr. Vijay, for calling me here. And of course, thank you, audience, for sparing your Saturday afternoon for this academic session. So I've been asked to speak on precision oncology and hematological malignancies. Very frankly speaking, this is more of philosophical topic, but because I've been asked to do so, I'll do it in next 10 to 15 minutes. So when we talk about practicing oncology in 2026, we cannot shy away from talking about precision oncology, because what we are practicing now is precision oncology. So this is basically right treatment for right patient at right time, and this is what is precision oncology. It starts right away from diagnosing patient with up-to-date diagnostic modalities, giving them targeted therapies, and of course monitoring their clinical outcome with precise technologies. Now gone is the era. When I say gone, it is not completely gone, but now we have shifted from morphology to molecular based techniques when it comes to diagnosis. Now we don't talk about one size fits all chemotherapy. We talk about targeted therapies and immunotherapies, and that is what defines precision oncology. So as we discuss diagnosis, risk stratification, then treatment, monitoring, and post-treatment care, at every aspect we are actually following precision oncology. There is a basic difference when we consider pediatric as well as adult tumors. In adult tumors, as the patients grow, as the population age, there is high mutational burden, vis-a-vis pediatric tumors where there is lower mutation burden, and pediatric tumors are more amenable to practicing precision oncology. When we compare blood tumors, that is hematological malignancies, with solid tumors, the blood cancers would lead precision oncology in every field, right from diagnosis to treatment. We have seen in the previous lecture that CML actually is a flagship disease which defined precision oncology right from diagnosing, identifying Philadelphia chromosome, identifying the mutation, defining TKIs and post-TKI care. Same is the case with AML, BALL and so on. So many diseases in hematological field are now treated with precision oncology. In precision oncology, the diagnosis would start with newer technologies, newer advances like flow cytometry. Now we know that in 2025 we cannot diagnose any leukemia without application of flow cytometry. We use FISH, we use karyotyping, NGS to diagnose and to risk stratify, as well as when we monitor the disease during treatment. MRD is the most important modality when we talk about precision oncology. We regularly employ use of MRD in the treatment of ALLs, AMLs and so many pediatric disorders. The MRD is assessed using flow cytometry, which can detect up to 10 raised to -4, -5 cell level and so on, going up to NGS, where MRD can be detected at the level of 10 raised to -6 cells. If with NGS, if the MRD is negative, the patients are operationally cured of some particular disorders. So this is the tip of iceberg, and under the tip of iceberg we have MRD 10 raised to -4 with flow cytometry, -5 with PCRs, and still deeper we have NGS negative MRD, where the cell count is actually less than 10 raised to -6. CML is the baby which defined precision oncology. Probably 50-60 years ago, Philadelphia chromosome was identified. Imatinib got first approval, FDA approval for the treatment of CML, because this was one of the first targeted agent, and now this actually opened the chapter of precision oncology. Over the years we had nilotinib, dasatinib, asciminib. Of course in pediatric population asciminib is not approved, and so on. So many molecules, TKIs are being approved, and that is how CML actually opened the way of practicing precision oncology. Same is the way with AML. Of course in pediatric population we do not have approvals for so many molecules, but in adult oncology, when we identify particular molecular mutations, we have drugs like midostaurin, ivosidenib and so on. And when particular mutation is identifying using precision oncology techniques, the treatment are devised so that ultimately PFS, OS would improve. And that is how in every disease where we practice, where we treat patient with hematological malignancies, we are somehow or the other employing precision oncology, right from the diagnosis, monitoring of the treatment and giving them treatment. The flagship disease of pediatric population is acute lymphoblastic leukemia. If you look at the survival curves, 60 years ago the survival was very dismal. Over the years survival has improved. In fact, in pediatric acute lymphoblastic leukemias in standard risk group, the overall cure rate, overall survival has improved up to 90%. You can imagine, for pediatric ALLs, 90% of the patients who are diagnosed as having ALL would be cured of the disease if they are treated properly. Now this is not simply because of improvement of supportive care. Of course improvement in antibiotics, monitoring, improvement in antifungals has given this, but use of precision oncology at every step, right from diagnosis up to the treatment, has written the success story of acute lymphoblastic leukemia. To give you an example, in acute lymphoblastic leukemia in pediatric population, those patients who have translocation 1221, those patients who have hyperdiploid chromosomal pattern on their karyotype are classically are classified into standard risk group, vis-a-vis those patients who have infantile leukemia and particular genetic rearrangements would be classified into higher risk leukemia. Now this is where precision oncology will come into picture, because those patients who have higher risk leukemia would ultimately go ahead with bone marrow transplant, vis-a-vis those patients who have standard risk leukemia. There at some point of time therapies may be de-escalated using MRDs. In ALL, pediatric ALL, of course this is not only for pediatric ALL, this is also for adult ALLs. There are so many targeted drugs which can be used in the treatment of especially B acute lymphoblastic leukemia. In pediatric populations we use blinatumab. In adult population we have inonza, inotuzumab. there are certain other molecules, targeted drug, which otherwise were not available 20 years ago, and with the availability of these targeted drugs, the overall survival in pediatric as well as adult population has increased. Now, when we talk about treating pediatric acute leukemias, we cannot forget MRD, minimum residual disease, because this is what would define precision oncology now and in coming years. There are different protocols by which we would be treating pediatric ALL, and we use MRD, assessment of minimum residual disease, at different time points like day 29, day 70 and so on. And depending on the MRD levels, because MRD actually is a game changer in pediatric acute leukemias, where for BLL specifically, if the MRDs are negative at particular time point, the therapies can be de-escalated, the therapies can be downgraded, and that is how ultimately the toxicity of therapies would come down. Now this can be compared with those patients who have MRD positivity at day 30, day 70. These are the patients, they would be classified into high risk category. These patients were actually missed when MRD was not available, and these patients would undergo allogenic stem cell transplants. So you can see the event-free survival, relapse-free survival for pediatric patients where MRD is negative. Almost 90% of the patients would get cured with MRD negativity, and those patients who have higher MRD, even at the end of treatment, during the treatment, almost 60% would relapse. These patients were missed when precision oncology techniques were not available. Now, apart from ALL, AML, there are other disorders in pediatric population. Lymphoma is one of them. In pediatric population, we see Hodgkin lymphoma, non-Hodgkin lymphoma. There we have targeted drugs which were not available probably 10 years ago, 15 years ago. And with this use, with the use of targeted drug, the overall survival has improved. So what is the ultimate goal of using precision oncology? 20 years ago, the goal was treat to progression, go on giving chemotherapies, treat till progression, till the time patient has progressed, patient has stopped responding, or patient is not tolerating chemotherapies. So that actually led to toxicities, financial toxicities and resistance. But now with precision oncology, with specific drugs available, with the use of MRD, the goal has increased, the goal has shifted to improving overall survival, reducing the toxicities, ultimately improving the quality of life. There is something which is called CAR T cell therapy, which Dinesh Burani sir would be discussing in the afternoon hours. But when we talk about precision oncology in 2026, we cannot forget CAR T, because CAR T would define the future. CAR T cell therapy, these are living cells which are taken out from patient's own body, they are modified and then injected. These cells are like army, they go into patient's body, they identify tumor cells and would specifically kill the tumor cells. Right now in India, we have CAR T available for two specific disorders. First is acute lymphoblastic leukemia, B variety. The second is DLBCL, NHLs. For other disorders like AML, multiple myeloma, we don't have CAR T available in India. Outside India, it is very much available. So CAR T is something which would define the future of precision oncology. Apart from that, there are so many newer things coming up. There are some antibodies, antibody drug conjugates. Of course, for adult patients with myeloma, Hodgkin lymphoma, and other disorders where newer antibodies are coming up, bispecific drugs are coming up. This has actually revolutionized the way we treat these patients. So when we talk about precision oncology specifically in pediatric population, pediatric B-cell, ALL, acute myeloid leukemia, the picture has completely changed with the improved diagnostic modalities, with improved monitoring and newer treatment options. In pediatric population, we cannot forget about late effects, because these pediatric patients, when they grow up into adults, they would carry the burden of side effects of chemotherapies which they have received 15-20 years ago. So precision oncology definitely helps minimizing the side effects, because using precision oncology, we are actually avoiding some drugs, de-escalating treatment and so on. So what is the future of precision oncology or hematology? Right now we have antibody drug conjugates, we have BiTEs, we have CAR T cells. Probably 5 years down the line, we would have newer CAR-T technologies, we would have improved genetic understanding of hematological malignancies, and maybe 10 years down the line, the whole genome sequencing would be a default test for each and everyone who is diagnosed with hematological cancers. We would have more and more indications for CAR-T cell therapy and so on. But when we glorify precision oncology so much, we cannot forget about challenges. In India, where we practice, the challenges are many. It starts right away from availability of technology, quality control, cost, ease of access, and so on. But having said that, the future of precision oncology is bright. In fact, present is bright. We are 80% of the time what we are practicing is precision oncology, and as we have seen, there is a bright way ahead for precision oncology. Thank you so much.
Anyone wants to ask a question? Anyone? So I think Vinay has taken this subject from the now to the 10 years down the track, what we are expecting. Anything we want to know?
No questions.
I would like to add one thing as a hematopathologist is that now, because of precision oncology, it is our turn that we should know about the treatments because they are changing the picture of what is happening in the lab.
Right.
So now with all these newer drugs which are targeted therapies, pathologists cannot be aloof from treatment and just sit and watch their slides and flow cytometries. We need to understand the impact because as the treatment is changing, our panels are changing. So first CD38 was a marker. For example, now we have daratumumab in the precision oncology era, a targeted therapy. So we have CD38 negative cells. So then we have to change the type of antibody that we are using, just giving you an example. And we have to use additional markers like 229 or 319. Same for the BALL.
Right.
So a proper history given to us and how we use the history to interpret is very important. So hematopathologists have to know the treatment side of things.
Right.
I think the technology is changing very fast. So we had even AI and the machine learning is coming in. We are getting more precise for the treatment, not that chemotherapy. Now we have the immunotherapies and living drugs, what you are talking about. With this, I thank Vinay.
Thank you.
We'll thank Dr. Srivastava for giving us the opportunity, and we close this session. Thank you all, panel.
I'll also request Dr. Akshay to please join us for the group photograph. I'll request Dr. B.R. sir to join us on stage. I think we have had very scintillating discussions. Now, in the interest of the time, as Dr. Swati has a flight, I'll request the permission of Dr. Shalini ma'am and Dr. Yashodhara ma'am if we can have the panel discussion first. I'll invite the moderator, Dr. Swati Shah. Dr. Swati, she is a MAMC alumnus and has done her DNB surgical oncology from RGCI Delhi. Currently, she's practicing at Apollo, Ahmedabad, with keen interest in pelvic surgeries, laparoscopic and robotic oncosurgeries. We're very happy to have you, ma'am. We'll ask you to please invite your panelists.
Thank you for the warm welcome and for the opportunity. So here I first like to invite my panelists. So please Dr. Vijay Chaudhary, Dr. Anju Verma, Dr. Kishwar Sultana, Dr. Hiya Agarwal, Dr. Ravi Ambe, and Dr. Monica Diwan. Yes. So Dr. Vijay Chaudhary is pediatric hematologist and oncologist. Dr. Anju Verma is gynecologist and infertility specialist. Dr. Kishwar Sultana, gynecologist and gynec oncologist. Dr. Hiya Agarwal, gynecologist and infertility specialist. Dr. Ravi Ambe, pediatrician. Dr. Monica Diwan, gynecologist and gynec oncologist. Myself, surgical oncologist, basically doing uro and gynec oncology. So a slight difference in the topic that we have been discussing may not appear that much interesting to you, but let me tell you, this topic has been brought up because of the efficiency, or rather the survival rates that we have been discussing till now, because the survival in the childhood cancers has increased to such an extent that it is the time we have to discuss the sexual health and fertility preservation in these patients. So for pediatric cancer survivors, we have our next session, that is the sexual health and fertility preservation. So let us start with the first case. So a 15-year-old girl undergoes fertility sparing surgery for malignant ovarian germ cell tumor. Chemotherapy is also planned. Now parents are asking about the future menstruation, fertility and marriage. So my first question to Dr. Kishwar ma'am, as a gynec oncologist, in adolescents with ovarian germ cell tumors, how aggressive should the surgery be?
The germ cell tumors which occur in less than 30 years of age, though they are aggressive tumors, but they are very sensitive to chemotherapy and radiotherapy. So the treatment is not very aggressive. Moreover, they are young patients, so we want to preserve their fertility as well. So in these patients, we usually prefer fertility sparing surgeries, and that includes the usually one-sided salpingo-oophorectomy, peritoneal washings, and probably infracolic omentectomy, or in very early cases when the omentum is not involved, we may not even remove the omentum. Lymph nodes, if they are enlarged, then they are removed, because the incidence of lymph node metastasis in early disease is very low, that is 7 to 10% only.
So thanks madam. So it is very important to preserve the fertility, and please remember, this is the only cancer in which we can preserve the fertility even in stage 3 and 4 cancers if the ovary and uterus is normal. So now coming to the fertility specialists, what fertility counseling should happen before the chemotherapy? Dr. Hiya?
Ma'am, it depends as of your patient. If she's a 15-year-old, mostly patients with this age are menstruating, so I would like to assess the reserve, and a menstruating girl can be counseled about the standard approach of fertility preservation, that is oocyte cryopreservation. So if she's menstruating, her reserve is good, and I have time before chemotherapy, I would like to give her random protocol, preserve the oocytes, and then go ahead with the chemotherapy.
So with this first, ma'am, how many of us do send the patients to you before treating?
It's definitely a novel approach, and definitely in Gwalior, it's not a norm. We are hoping as a reproductive medicine specialist to increase this as much as possible. That's the aim in the future.
So it is actually a lacunae. We should have this insight that this is a lacunae that we all have as the oncologist, or whatever field we are related to the oncologist. It is very important to remember the fertility specialist which is available with us. So we should always have the consultation before starting any treatment. Yes. So thanks for your comments, madam. Now coming to Dr. Ravi Ambe. Sir, the patient is, parents are very anxious, patient doesn't know much. So how do you because you are the primary face to these patients. So how will you counsel? Everything they will come to you and ask. So how will you counsel these patients? First is cancer, and first the other thing is the fertility.
Yeah.
Thank you, ma'am. As far as anxiety is concerned, it is part and parcel of cancer suspicion, diagnosis, and treatment. So, these ovarian germ cell tumors, malignant, usually these are rare, but are more common in this pediatric age group, adolescent girls, and the young women. And the prognosis with the contemporary treatment with BEP regime has improved a lot. So in stage 1, it could be better than 95% 5-year survival to 75 to 85% in the advanced disease. So cure is not a problem. We have a good cure, good treatment. As far as fertility and sexual function they are concerned, that is another area of concern. And in this era, when the cancer is far beyond the cure to survivorship, and that to a good quality life, I think this is the real concern of the parents, and we should be empathetic. I mean to say pediatrics, okay? We should be aware of that, and we should be empathetic to that, and should discuss it with the parents, and we can act as a sheet anchor, as a team member for this management. And this chemotherapy, though it is having good cure, but it is going to affect the endocrine function, ovarian function. And as the Dr. Hia rightly said, that this is not a norm in our present era of practice. We need to sensitize ourselves as well as the parents. And as said before, the survivorship should be taken as a holistic, not limited to the cure of the patient. And I think this is going to boost the confidence of the parents as well as the patient. Thank you.
Thank you. So this was the first question. So with every question, the take-home message is, please do remember the holistic approach as said by Dr. Ravi, that it is the holistically the patient has to survive. It is not only the quantity of life, it is the quality of life also that we are responsible for. Coming to the next question. So testicular germ cell tumor question, a 16-year-old boy with metastatic testicular cancer requires urgent chemotherapy. So many a times we oncologists save ourselves from sending to fertility specialist by saying it was urgent. The surgery was required urgently, the ovary had to be removed, the testis had to be removed. So believe me, there are situations which are urgent, but we have to manage them. So the patient required urgent chemotherapy, and family asks whether treatment will affect fertility and the masculinity. So first question to Dr. Vijay Chaudhary, should fertility preservation delay chemotherapy in testicular cancer? Answer more regarding this.
See, we can delay for few days, but ideally speaking, should not be more than few days. We can't say that you delay for 2 weeks or 3 weeks and then do. There are methods available for fertility preservation. He is a male, he can simply do a semen cryopreservation, which is a very small procedure. 2 or 3 samples would be sufficient. Another method is testicular sperm extraction, but priority is cancer treatment. We must understand this. Unless you live, there is no chances of fertility. So please understand this. We can delay if we counsel them adequately. We give them option that okay, semen cryopreservation is available. We give them appropriate address and the name of the consultants. They will go there. They will cryopreserve the semen sample, come back in the same week, and we start the treatment. So not more than few days. I would say that's it.
So very correctly pointed out, though the message is quality of life is important, but first comes the quantity. So yes, the cancer treatment should not be delayed. So we should be aware of the fertility specialist available near to us, what all treatments are available, how fast they can be done. One sperm banking, how much time it should take. So now coming to Dr. Anju, please guide us regarding the same, how sperm cryopreservation is done, what are the practical aspects.
Thank you, ma'am. Just in this case, a male is 16-year-old. In most of the 16-year-old boys have ejaculation. So we can counsel parents to preserve the semen, but it should be preserved in the registered ART bank. I want to inform that our center is registered ART bank in this Gwalior Chambal division, and many cases we have also preserved the sample like in lymphoid and leukemia. So we can counsel parents that we can preserve the semen, but we should also coordinate with these oncosurgeons, oncospecialists, that how much time. Even one single sample have more values. So we can sample, preserve one sample, if there is permission, 2 to 3 sample, and we again counsel the patient and parents that this may be used in future IVF ICSI. We should also counsel the advanced treatment, what is the rate, what is the success rate, but we can do this because after therapy, there is very less chance of this availability of the sperm.
Thank you, ma'am. So the idea is whatever field we are in, but if we are related to oncology, we have to know about these fertility nuances so that we can help our patients. So Dr. Monica ma'am, what sexual health concerns are commonly overlooked in male survivors?
As the importance of today's this panel is again saying the importance. Basically, in the male survivors, at the time of treatment, starting from the treatment, we forget about their sexual and the psychological health. We mostly focus on the cancer-related treatment. As in this boy, the treatment, chemotherapy or the surgery leads to the decrease in the testosterone hormone, which further leads to effect of the decreased testosterone, like decrease in the sperm count, decrease in the libido, which further lead to affect her psychological effect, like the body image, their sense of masculinity, and this further lead to her personal and the social life. So we should focus over these aspects also at the time of advising the adolescent for the treatment.
Thanks, ma'am. So coming to the next case, pelvic radiation in cases, different cases. So a 13-year-old girl with pelvic rhabdomyosarcoma requires pelvic radiotherapy. So now coming to the effects of Dr. Monica Diwan, coming again to you. What are the long-term sexual and reproductive consequences in pelvic radiation?
So if we talk specifically about the long-term sexual and the reproductive consequences, so the ovary is the very sensitive organ. So radiations lead to effect of decrease in hormones, the estrogen hormones, which lead to the ovarian failure, which further affect her secondary sexual characteristics like the breast development, and the vaginal exposure of the radiation leads to fibrosis at the vagina, dryness, which further leads to the vaginal stenosis. And as I already told, the decrease in the hormones, specifically the estrogen, affect her puberty. The effect of radiation over the uterus again lead to the fibrosis, and the decrease in the hormones lead to the decrease in the growth of the uterus. So the uterus again small in size, which further leads to the obstetric complications like difficulty in getting pregnant. If she gets pregnant, leads to the abortion and other effects.
So much to discuss before starting any treatment in these patients. So coming to Dr. Kishwar Sultana, madam, as a gynecologist and gyneco-oncologist, what are the things that we can do to these patients before they are going for radiation?
If we talk about the surgery, we can preserve, means we can protect the ovaries by doing ovarian transposition before pelvic radiation. And in this ovarian tissues, they are taken with their pedicle out of the pelvic brim in the paracolic gutter or lateral to the psoas muscles, and so that their exposure to the radiation is minimal. And in this, like the ovary is stitched to the peritoneum, and it has been shown that if the brachytherapy is given, the ovaries, they regain their hormonal activity up to 90%, and if there is external beam radiation, around 50 to 60% of the hormonal activity of the ovary is preserved. And there is, in some cases, about 30 to 40% they may also conceive later on.
So yes, ovarian transposition is an option for these patients. So we should remember that this will take 2 to 3 days because the patient will go to a surgeon, though it is done laparoscopically, but 2 to 3 days is the minimum. We can start with the main treatment, that is radiation. So things we should be knowing about before starting the oncology treatment. Coming to Dr. Hiya again, if ovarian function is lost despite transposition, what options remain in these patients for hormone as well as fertility?
First of all, I would like to add, like when we are planning transposition in this era, we can plan along with it ovarian tissue cryopreservation. That way, answering to your question, we don't have to go because some things cannot be come back. We cannot return certain things to the patient. So definitely we can take some tissue when we are transposing and preserve it so that we have something to answer to the patient at the time when we are, because how ovary will respond, nobody can predict. We can just make an estimation of it, but cannot guarantee it. Other than that, if we have not done and the patient has come to us and she is slightly older in age, more than after 30 years we are doing, she is a young patient, most of the chances that ovary will respond, at least hormonal function will come back. And if not, we are not getting, then there is an option of donor oocytes if it's not, the ovary is not responding at all.
So, madam, regarding the OTC, we have been discussing about the OTC in various we have regular pelvic oncology and fertility conferences. So, the OTC is not available at most of the centers. That is what we know. We will be thankful if you let us know, because we have been asking that whatever centers who have the OTC, please let us know.
Up until recent, it was experimental. It has become a clinical option recent years only. So, coming to in India as a clinical option, it will take some time. My plan is to bring it to Gwalior, but so it will take
I'll
time.
just request, whenever you start it, please post it in the groups so we know where to send the patient so that OTC can be done. So that is the request from our side as the oncologist, though we don't send pre-op, but if you let us know, we might start doing that. So yes, so that was about this case. Now coming to the, since hemato-oncology, bone marrow transplant survivor, a 12-year-old girl undergoing BMT for leukemia requires high-dose conditioning therapy. Family asks about puberty, fertility, future quality of life, because the survival has increased. Now, Dr. Ravi sir, you have to answer the major long-term, whatever we can do for these patients, whatever are the concerns for patients undergoing bone marrow transplant regarding the fertility.
So again, here the results are very good as far as cure is concerned, treatment is concerned. But yes, long-term effect of conditioning therapy, bone marrow transplantation, immunosuppression, and chemotherapy are going to happen. So one of the major concerns, this is a 12-year-old girl. So there is concern for the premature ovarian insufficiency, and it will lead to, if the puberty has occurred, it may arrest the puberty, or if the puberty has not taken place in her, so it will delay the puberty. So that is the one of the concern. Then it may also cause the premature menopause. This is a girl and who has to who is supposed to go through the sexual life, but due to this she might experience those premature symptoms. And this is going to affect the growth of the child as well, because of central, as it is going to affect the HP axis, radiation as well as chemo, and it is going to affect the growth plate of the spine. So we need to monitor for that. And these are the other endocrine organs, especially adrenal, thyroid, they are also being affected by this. So as a holistic, these endocrine organs, especially ovary, thyroid, pituitary, need to be taken care of, need to take care of the growth of the child, and accordingly this survivorship, parents again should parents should be sensitized from the starting that this cancer is not up to the cure, it is for the survivorship. So holistic care of the child may require decades of dedicated follow-up.
So well said. While managing pediatric cancer, starting from pediatricians now up to the menopausal specialists are involved, because we are dealing with POFI, that is ovarian premature failure. So coming to Dr. Anju ma'am, what fertility preservation options should be considered before BMT?
if we are talking about this particular case, we should ask the girl that whether she is menstruating or not, and should also coordinate with the oncologist that we have time 10 to 14 days if we can delay bone marrow transplantation. Because if there is 10 to 14 days and girls is menstruating, it's good to preserve the oocyte after stimulating the ovary. Because oocyte preservation is quite common, we are also doing, but ovary preservation in this era is still there is only experimental basis. Even some centers are doing, but it's good if we have menstruating girl and 10 to 12 days we stimulate the ovary, retrieve the oocyte, and we can keep for the frozen oocyte. But if not menstruating, then we should offer the patient for cryopreservation of this cortical tissue. We can retrieve either laparoscopically and preserved, stored, and after treatment we can reimplant. But because this is leukemia, this ovarian tissue may have the cancer cells. So again, after reimposition or implantation, there is little risk of again spreading. So we should counsel the patient. It's better to do oocyte cryopreservation.
Thanks for pointing out that, ma'am. So for the final discussions, I will ask Dr. Vijay sir, should fertility counseling become mandatory before gonadotoxic therapy in children and adolescents?
Absolutely yes. We regularly do this. Any kind of chemotherapy we are giving, the counseling is absolutely mandatory before that.
So for the final discussion, if we have questions or the panelists want to have some discussion on the related topic.
It is necessary and it is debatable as of now, because the infrastructure, the cancer care, the financial status, and the urgency to treat, these are the critical factors which need to be considered.
I think,
before
madam,
making it mandate.
Everybody should aware that whether treatment is available and where it is available. Because lack of knowledge, many patients, parents are suffering. But if we can spread the knowledge in our city, in our area, where we can do all this, it's always good to do multidisciplinary approach.
Ma'am, I agree. We should aware about this, but as our patients are not very financially strong, so we have to look this part also. We counsel, but most of the time, because of the cost of these all preservation effects, they are not able to afford these type of things.
I can say sperm cryopreservation is not very costly. 10 to 15,000 we can use 1 to 2 sample, and oocyte cryopreservation, because we required stimulation, so it is costing about one cycle of IVF about 1.5 lakhs. So sperm cryopreservation is not very much costly.
So I would like to say, whenever you are making us aware of various things that are available, like whenever the OTC is becoming available everywhere, let us know about the costs at various centers, so that we can offer the patients in whatever financial strata they belong to. At least more and more patients can utilize the facilities which are available at various centers. Thank you. Thank you.
Thank you so much, ma'am. And Hanji, please.
First of all, I think this was an excellent session and much needed because we often forget to talk about this aspect. Just one or two things I wanted to ask the IVF doctors, right? So how easy is it to create an embryo from the ovarian cryopreserve, which we have preserved for whatever 20, 30 years? Because what I understand, it involves a huge amount of cost also.
Ma'am, it's not easy. It's, as of now, it was experimental till 1 or 2 years back. It has now become an option, but not so much available in India, not so much in India. Outside only we have case reports. There are only around 200 live births from that cryopreserved ovarian tissue. So as far as the science go, we cut the cortical pieces, we freeze them, And when the oncologists recommend, and when we feel that it has been 6 months or 6 to 7 months after the completion of the treatment, after remission, we transplant them back for the ovarian function. Usually, if it's possible, we do it in the area the way the ovary is in the adnexal regions, or if it's not possible, then in the subcutaneous fat. It's easier if we do it in the subcutaneous areas like arms and all, in the stomach, because then it's easier to get the oocyte. When we stimulate them, it's easier to get the oocytes. Because normal reproduction will not be possible. We will have to do IVF for these people.
Madam, tissue cryopreservation is difficult and impractical in India still now, but oocyte cryopreservation, and if the patient has partner, we can also cryopreserve embryos. So it's a very, very common, and nowadays it's very common to preserve the oocyte, preserve the embryo. We are also doing. But cryopreservation of tissue is still not very, very done usually, so it's difficult.
I can completely understand that. So that's why we get stuck in children and adolescents, because all these things are not available. Just one more thing I wanted to ask is, in the Indian scenario, I'm sure all of us observe, there's a girl, say germ cell tumor, and you start counseling them about fertility, there is a good chance that the family will say, Jane do, why to treat if she's can't bear children. So that is one big fear. I'm sure you will also agree that we need to assess with which parents we need to discuss this. If we're going to discuss it as a rule with every parent, we run a risk of abandonment. I just wanted to sensitize that.
I'm totally agree. Most of the time we counsel the parents and they say, no, जाने दो ma'am, आप तो बस cancer का इलाज करो.
No, I'm saying about something else. I'm saying if you counsel that this girl, especially girls in India, that she cannot bear children, they will stop the treatment for cancer as well. You know, there's no point in saving her. That is
it is like that.
Yeah.
Madam, there is a one treatment if patient don't want to preserve the ovarian tissue oocytes, and we starting during chemotherapy, radiotherapy, we can give the GnRH agonist, leupride injection.
Yes.
This create little less damage. Yes. So if the patient is not ready for doing anything, you just give the leupride injection in every 3 months. It keeps on silent ovary and there is less damage because there is no active oocytes.
I agree to that.
Thank you so much, ma'am. Thank you so much to our panelists. Now, I would request you to come forward, please, for the group photo. I would like to call chairperson of next session on stage, Dr. Ajay Gaur sir, Dr. Ashok Panga sir, Dr. Ajay Pal sir, and Dr. Rajni Agarwal ma'am. Please join us on stage for next session. Yes.
Consultant and Head Pediatric Surgical Oncology at Rajiv Gandhi Cancer Institute and Research Center. She is Chair Wilms Tumor Subcommittee of INP-HOG, Country PI for SIOP Umbrella India's study. She is member of ARIA Guide Program for Wilms Tumor. Her area of interest is pediatric solid tumors, central venous access devices. Now, Dr. Shalini Mishra, please.
Thank you, chairpersons, for the kind introduction. And without any further delay, I think we are running already late. I'm really honored to be here today. Can you please put up my slides? The same one? Okay. Right. So can I just have a show of hands? How many are students here? Quickly. Okay. Thank you so much. So I'm going to wake you up. I want this to be a little bit interactive sessions, and this session is mainly meant for you. All the other people, they already know what I'm going to talk about. And I'm really I'm very happy to see so many of you. So I'll be talking about the approach to abdominal mass in a child. We know that the abdominal masses in pediatric age group, they have a whole line of diverse origin and significance as well, right? And it can occur at any age. So unlike the adults, when we look at a child with an abdominal mass, the second thing after mass, we see what is the age. If somebody calls me up and tells me about a child, then my first question will be, what is the age of the child, you know? Because the pathology can vary depending on the age of the child. And also different clinical presentations. And another challenging thing is sometimes it's not easy to diagnose it alone. You need the whole team, pediatric oncologist, pediatrician maybe, the surgeon, and the radiologist and pathologist sometimes to sit down and crack the diagnosis. So they can be very challenging as well. So I'll be briefly discussing the various types of cystic and solid abdominal masses and also how to reach in diagnosis, kind of an algorithm I'll discuss. So as I mentioned, the site is very important. So you need to see where exactly this tumor is arising from. And also some of the, you go back to your general surgery posting and revise your abdominal mass examination, whether it's a mobile mass, whether it's bimanually palpable, which quadrant, can you get above it, can you get below it, all those things are very important. And the age, I've already said, and the duration of history, because if it's acute, then you can pinpoint that it's probably inflammatory or infective etiology. And very often, at the end of examination, we can just about come up with a differential diagnosis, which is fine. And then we can decide which investigation to take. And what is our aim? We have to reach the correct diagnosis cost effectively. We can't just run a whole battery of tests on every child which comes with an abdominal lump. It's not possible. I'll discuss that later. And with the least distress to the child. This is again very important because often the procedures will cause pain if you're doing a biopsy or a blood sampling or will require anesthesia. So we have to try and plan it out so that the child, the parents do not get too distressed, too overwhelmed with the diagnosis itself that they will just, probably say no for the treatment. So some of the normal, can somebody tell me what are the normal abdominal masses in children? Some structures you can feel, oh, there's a mass, but actually it's a normal structure in the abdomen. Anybody? The liver, a soft liver can be palpable in an infant and sometimes little older child. What about a feculoma? Child has a constipation. I'm sure in general surgery exam or in clinics, all of you have faced a patient, especially a child with a feculoma, and you thought it's a mass, but it's actually just a feculoma. And a full bladder, of course. So we just have to be aware about the normal conditions and the less rare things before we just jump into a tumor. It's not necessary that every child which comes with a mass has a tumor. So very grossly, we can divide them into cystic or solid masses. So I hope you can see this table. So if you want, I can share these things with you based on the location of the mass. I have just classified them as solid or cystic. So flank mass, very obviously what comes to our mind is the renal mass. So you have all the benign ones which are much more common, hydronephrosis, PUJ obstruction, polycystic kidney, multicystic kidney, all those things are much more common than your tumors. But when you come to the tumor, you think about a solid flank mass, then Wilms tumor, neuroblastoma, and you could even have an adrenal tumor there because the location is similar. And of course, you can have, things like unrelated to tumor or anything like renal vein thrombosis in a small child, right? Right upper quadrant, obviously, it will be more related to the liver, the benign cysts like choledochal cyst, hydatid cyst, abscess, amoebic abscess, all those are much more common. And then you have hepatoblastoma, older children, you have hepatocellular carcinoma, and then you have the benign lesions like hemangioendothelioma and mesenchymal hamartoma. Left upper quadrant, very simple, spleen, usually it's just a spleen enlargement, and usually you don't have a tumor, we don't see a tumor arising from the spleen. It could just be a splenomegaly, part of a thalassemia or any other hematological anomaly, pathology, right? Epigastrium, again, stomach and pancreas. So if you are aware of what the normal anatomy is, you can think of tumors or cysts arising from that particular area. And you will notice that retroperitoneal masses like neuroblastoma, teratoma, these can arise in any quadrant because they just arise from the retroperitoneum, right? And mid-abdomen could even be a lymphoma, a non-Hodgkin's lymphoma, and sometimes a paraspinal lesion can be a primitive neuroectodermal tumor and a pseudotumor. Sometimes just a horseshoe kidney, which is a pelvic kidney, it has failed to ascend and got stuck in the ascent at the inferior mesenteric artery. That could be palpable like a mass because of fused anomaly in a thin-built child. And of course, pelvis, we have to be careful about ovarian tumors, cysts, or it could be just be imperforate hymen with hydrocolpos in a teenage girl, and of course the malignancies. You could get rhabdomyosarcoma, of course germ cell tumors, and PNET as well. So as I said earlier, we don't jump into all the investigations as soon as we see a child with a lump. So usually any child with an abdominal mass, the first thing we will like to do is an abdominal X-ray, erect and supine, just to rule out an intestinal obstruction, because the child may be crying, you don't know whether it's a mass or it's a dilated bowel or is it ascites, you don't know what it is. Very often we don't do this unless the child is having some bilious vomiting and inability to pass stool. And then next step is the simplest one is ultrasonography. Because again, these are non-invasive. You are not, you don't have to sedate the child, don't have to give anesthesia, maybe just oral pedicloral should do for these. And based on what you find on the ultrasound, I think ultrasound is a very important investigation. And I always think that wherever you're working, however small place or a big place, you have to have a good rapport with the sonologist, especially when you're sending a child. And if you have somebody who is specialized in that, it will be very, very helpful. It may not be a very senior person, it could be your colleague or your classmate from college or somebody with whom you can discuss, because sometimes they may see some things, it's very subjective, and they may imagine a few things and you know what you're looking for. So if you discuss with them, you will get a better answer, and whether or not to do further imaging, that's the biggest question. Of course, often like in renal tumors, we couple it with the Doppler because it tells us about if there's a renal vein thrombosis or a IVC thrombosis associated, and then the CT scan. And sometimes if you're thinking of a cystic mass like PUJ obstruction, you will need a nuclear scan. Angiography very rarely. Can anybody tell me where we use a CT angio? Which tumor in children do we use a CT angio as a diagnostic method? Anybody? Something which encases the vessels, at least before surgery, neuroblastoma, right? Okay. And then of course, slowly more and more MRI is being done. We know it's good for soft tissues, so for sarcomas we definitely do, for head and neck we do, but for abdominal masses also, for liver tumors, sometimes we get a better delineation with and calculation of the volumes and multiple foci of the lesion in the hepatoblastoma. That is much better picked up on MRI. And even for renal tumors, like for bilateral Wilms or a horseshoe kidney, MRI is preferable. So ultimate goal, again, we have to get the diagnosis, we have to get it quickly, and you have to improve, you have to get the child better, right? So depending on the age of the patient and the presenting symptoms, you will decide which imaging process. So I'll just quickly take you through some kind of a algorithm. I hope it's visible. Okay. So you have a child with a suspected abdominal mass. So first thing I said, we can do an abdominal radiograph. It's any intestinal obstruction, then you treat it accordingly. No intestinal obstruction. Can you figure out an abdominal mass on an X-ray abdomen in a child? Yes or no? Something, you just say. There's nobody marking you here. Can you figure out an abdominal, it's a huge abdominal mass. Will it show on the X-ray? Can it possibly show on the X-ray? You can get a, a whiteout area where the mass is and all the bowel loops are pushed to the periphery. So that can give you an indication that there's a large mass over there, because all the bowel, which is usually seen in the center, is now pushed to the periphery. So you do an ultrasound, because X-ray is normal, and based on what you find on the ultrasound, what is the site, what is the organ of origin, you can get all your details based on the ultrasound, right? And if the ultrasound is normal, then that's it. It was probably the bladder you felt, or a fecaloma or something like that. Nothing more to be done. And if it is abnormal, you get more details. For example, you get a renal cystic mass, then you'll work up like a PUJ obstruction. If you get a renal solid mass, then definitely you need to do further imaging like CT, contrast CT. Again, non-renal retroperitoneal mass, again you will need to do a CT. Hepatobiliary mass will also need further imaging. And sometimes if you're thinking about a choledochal cyst or something, you may do a HEDA scan. A genital mass or a pelvic mass, again, sometimes if you think it's a rhabdomyosarcoma of the vagina, then you may need to do a genitogram or a genitoscopy and biopsy. And of course, sometimes for bladder masses, you may need to do a MCU. So based on the age, now I definitely want at least one or two answers. I know people are talking at the last row, but I want you to concentrate and just blurt out anything that comes to your mind. In a neonate, if I tell there's a solid abdominal mass, just name one or two things which are more likely to happen. Which tumors? Either it could be just benign, which is much more common, any, malformations, duplication cyst of the genitourinary tract or gut, right? That is much more common. And if it's a solid mass, then neuroblastoma is the most common solid mass in a neonate. Every time we think it looks like a renal mass, but when you work up, it finally comes out to be neuroblastoma. And these are the ones which will actually spontaneously regress. So we don't need to really act on them, but we do need to classify and stage them and make sure that they are not progressing. Older infants, 1 to 5 years. Now this is where most of your solid tumors of the abdomen come. This is the most common age of presentation, right? The preschool age in the toddlers. And Wilms tumor, neuroblastoma, germ cell tumor, hepatoblastoma, all of them. And of course, sometimes non-Hodgkin's lymphoma. Adolescents, again, more likely to have inflammatory masses. And in teenage girls, you do need to rule out pregnancy as well. And of course, non-Hodgkin's lymphoma and germ cell tumors. So, based on the symptoms and signs, if somebody can answer this, I'll try and give you some chocolates. Incidental mass noticed by the caregiver and hematuria. A toddler. What do you think it can be? Yes? Wilms tumor, very good. Systemic symptoms like fever, irritability, failure to thrive, bone pains. All this is with abdominal mass. What is the most likely diagnosis? Very good. Excellent. You guys are good. Subcutaneous skin nodules in an infant and abdominal mass. Yes, again, stage 4S or MS neuroblastoma. Hypertension, it could either be abdominal mass and hypertension, can be both, neuroblastoma or Wilms. Pelvic mass with bladder and bowel symptoms may not be palpable, but just presence with bowel and bladder symptoms. It could be a sacrococcygeal germ cell tumor, Altman type 4. And a paraspinal mass with neurological deficits could be either PNET or neuroblastoma. So just some red flag signs before I take you through a few cases and then we'll finish. So any lower abdominal mass in girls, you have to be very, very careful about an ovarian mass. and it could even be a torsion of ovarian cyst if it's an acute abdomen. A non-mobile mass will tell you that it's likely to be a malignant one. Any child with a skeletal pain or pathological fracture, you have to think about metastasis, right? Sudden increase in size in the clothing, abdominal distension, you have to definitely think about ascites or an abdominal mass. A left-sided varicocele, although I rarely see one because we don't examine, that could lead you to a small Wilms tumor. I just want to mention, once I had a child who was kicked by his elder sister, a 5-year-old boy, on some festival day, and went to the emergency because he had abdominal pain, and they found he had a small Wilms tumor which ruptured with that abdominal trauma. So in the end, he actually landed up thanking the elder sister because that got his tumor diagnosed, and we treated him. And of course, systemic signs, we don't need to neglect them, right? And we have tumor markers to help. Many times if you get a raised alpha-fetoprotein in a germ cell tumor or a hepatoblastoma, we don't need to do a biopsy. A biopsy is again an invasive test, so we really think carefully whether to do a biopsy or not. Also, a lot of parents, if you tell them we don't need to do the biopsy, we've got your tumor markers, we usually get the AFP reports in our institute in 4 hours, and we've done the imaging, we've done the staging, like just CT chest for a germ cell tumor. By that evening, the child can get admitted and start chemotherapy. And of course, these are very small children. I'm talking about 3 to 4, 5-year-old. We can't do fertility preservation. We can't even think about it. So it's actually reassuring also, because the diagnosis is so stressful, and then you can start treatment quickly. They have this myth that biopsy will do something awful to the tumor and it's going to spread. So when you tell them no biopsy, it's not that I believe in that myth, but yes, biopsy is an invasive procedure. There can be rupture, there can be hemorrhage, and it can delay the treatment onset as well. So the decision has to be very, very, very carefully made by the whole team. And one important thing, if you're going to biopsy a renal tumor, suspected Wilms in a child, please do not do it transperitoneally. Please make sure, go there, go to the radiologist, make sure one of you is there, and make sure it is done through the retroperitoneal route, because otherwise it will upstage to stage 3. You have to upstage the chemo, add Adria, and also give radiation, especially if it's a less than 3-year-old child. Okay, so quickly I'll go through 2 cases. Whenever you want me to stop, I will stop. So the 3-year-old boy, well till 2 weeks ago, and then mother noticed this left-sided abdominal mass while bathing and 1 episode of hematuria. No systemic symptoms. So you can see there's a nice flank mass over here. You can see the bulge over there. It's hard in consistency, smooth in surface, well-defined margins. You cannot get above the mass. It's bimanually palpable, and there is dullness over the left renal angle. So all these things are very important. The blood pressure, checking the blood pressure of a child with an abdominal mass. So again, this is telling us towards a likely renal origin mass, and in this age group, most likely will be a Wilms tumor. And you don't need to do, if you're following the SIOP protocol, you don't need to do the biopsy routinely unless there is a radiological discrepancy. Could this be a tense hydronephrosis? Yes, it could be. So that's why your ultrasound is going to tell you that it's a cystic mass or solid mass, and then you're going to proceed with a CT scan only after doing. And always, wherever you're thinking of Wilms, neuroblastoma is always lurking around as a DD, because sometimes there's a very small gray area between the two. So I will just show you the image here. Can you see my arrow? You can see a claw sign, and the great vessels are not disturbed. Although this is crossing the midline, it's very clearly originating from the kidney mass, and it's a very large mass and very clearly a Wilms tumor. You can start on chemo without even a biopsy or anything else. Another child, so I'm just going to skip this. This is a 2-year-old with fever, weight loss, poor appetite, and then abdominal pain and mass, and then this swelling on the right eye. The mother said the child fell down from the bed, and the child landed up in the neurosurgery ward because they thought he had head injury, right? So you see there's a huge abdominal mass as well. So it's very important to examine the whole child and not get misled by that orbital sign. What is it called? Raccoon eye, right? So this is how the neuroblastoma looks, very irregular and oscillated surface. And I'll just show you the imaging. And definitely here you will need to do a biopsy. You cannot proceed without biopsy in neuroblastoma. You can see there's a huge mass here, and this is called the seagull sign, where the celiac trunk is encased and the aorta is encased 360 degrees by the tumor. Here also you can see it. So based on this, we will proceed. I think we're short of time, so I will just end it at this. If there are any questions, I'll be happy to take. Yes, yes. So please raise your hands. Those who answered the questions from that side. Yes. Please come up on the stage quickly.
Thank you so much. We'll move to the next one.
Thank you very much, madam. Such very nice discussion. Definitely there will be questions, but we can ask the question during lunch hours.
Now I would like to invite Dr. Yashodhara Gaur. Madam is MBBS, MS, FICOG, and Madam is Professor, GR Medical College, Gwalior. And Madam West Zone Coordinator, Foxy Oncology Committee, Founder President, MP State Chapter of Agoy, and President Gwalior of Gynae Society 2019-20. Madam,
thank you. Hello, good afternoon. First of all, I am thankful to the Director, CHRI, our Professor B.R. Srivastava sir, and dear Gunjan, and the organizing committee for giving me this opportunity to interact in a pediatric oncology conference. Initially I thought why I was called, but listening the talks of the speakers and the panel discussion, it's obvious that each and every patient of ours need holistic care, and for that multidisciplinary management is a must. We need to address the grey areas which are left, the gaps which are left in the management of the patient. Those areas must be filled. So starting with the my topic of germ cell tumors of ovary, they are derived from the primordial germ cell of the ovary. We all know the incidence is very less. We are fortunate that only 1/10 the incidence of malignant germ cell tumors of the testes are germ cell tumors of ovary. These malignant germ cell tumors not only they develop in gonad, but they are also found in the mediastinum and retroperitoneal areas, and this is because of the migration of the germ cell from the yolk sac to the dorsal mesentery before their incorporation into the sex cords of the developing gonads. It's very assuring and relieving that germ cell tumors are a model of a curable cancer. Management of the patients with ovarian germ cell tumor has largely been extrapolated from the much greater experience of treating males with the more common testicular germ cell tumors. So these tumors are less in number and they are curable one. These two important points are there. So this is the picture of a 3-week-old embryo showing the primordial germ cells in the wall of the yolk sac close to the attachment of the allantois. This is only 3 weeks when we are doing urine pregnancy test to confirm the pregnancy. Already the orchestra of the nature has set in the melody, and the primordial germ cell starts migrating towards the genital ridges. So this is the route through which germ cell goes from allantois, from near hindgut to the genital ridges. That's why the germ cell tumor can develop in mediastinum and retroperitoneal areas also. So germ cell tumor we classify on 2 points. One is the histology and other one is based on the tumor markers. Histological ovarian germ cell tumors are primary germ cell, primitive germ cell tumors, dysgerminoma, yolk sac tumor, embryonal carcinoma, polyembryoma, non-gestational choriocarcinoma, and mixed germ cell tumor. While biphasic ones are immature teratomas and mature teratomas, which remains benign, may be solid or cystic because of the differentiation of the cells. And then dermoid cyst may be there. Monodermal teratomas and somatic types are also there. There is thyroid tumor, stroma ovariae tumors which may be benign or malignant, carcinoid tumors, neuroectodermal tumor, carcinoma, melanocytic. So these are very different types of the histological structure carrying germ cell tumors, and according to that they function and they give sign and symptoms, and their management is decided. The second understanding of germ cell tumor is the presence of the tumor markers. Tumor markers like alpha fetoprotein, beta HCG, LDH, and PLAP are there, which are used in diagnosing, in monitoring the treatment, and in monitoring the recurrence also. So these tumor markers are alpha fetoprotein, as we all know that it is the major fetal plasma protein which is produced by the yolk sac and fetal liver. Its normal value remains less than 5.4 nanogram per ml, and it remains elevated apart from germ cell tumor in the NSGCT, hepatocellular carcinoma, omphalocele, ataxia, telangiectasia, and in its levels are reduced in Down syndrome. The next marker which we use in the management of the germ cell tumor is the beta HCG, which is used in diagnosing and monitoring treatment response in germ cell tumors in which it is positive. Other tests of this marker we are already doing in our routine practice: pregnancy test, gestational trophoblastic disease, management, diagnosis and post-treatment follow-up of the ectopic pregnancy, and as a component of triple test in antenatal care. The third marker which we use is the lactate dehydrogenase. The unique thing about lactate dehydrogenase is that it is a marker which is a reflection of tumor burden, growth rate, and cellular proliferation. So it may remain positive in all of the germ cell tumors. LDH, usually it is the first marker which shows a rising trend, but it is less specific compared to the other two markers, that is AFP and beta HCG. So these serum markers, how we influence their presence in the diagnosis and management. Both alpha fetoprotein and human chorionic gonadotropin are secreted by germ cell malignancies. Elevated levels can be used in differential diagnosis. Yes, one more marker is there, that is placental alkaline phosphatase and lactate dehydrogenase. It remains elevated in 90% patients with dysgerminomas, and serial monitoring of serum LDH level may be useful for monitoring in this disease. Embryonal carcinoma is composed of undifferentiated cells that synthesize both HCG and AFP, and it is the progenitor of several other germ cell tumors. More differentiated germ cell tumors like endodermal sinus tumor, that is yolk sac tumor which secretes AFP, choriocarcinoma which secretes HCG, and the immature teratomas which are derived from the embryonic cells and do not secrete HCG but may be associated with an elevated alpha fetoprotein. So we incorporate this finding of tumor markers presence with the histopathology. So in primordial germ cells, the tumors which develop are the dysgerminoma and embryonal carcinoma. In dysgerminomas, AFP and HCG both are negative, while in embryonal carcinoma, AFP and HCG both may be positive. From this embryonal carcinoma, further differentiation into embryonal and the extra-embryonic differentiation takes place, in which if in embryonic differentiation both AFP and HCG is negative in immature teratoma, while in yolk sac tumor AFP is positive, while in choriocarcinoma HCG is positive. So clinical examination, then the tumor markers, it will help us in reaching up to a diagnosis. You can see in this picture that LDH is positive in all these tumors, that is dysgerminoma, immature teratoma, yolk sac tumor, embryonal tumor, choriocarcinoma and mixed tumor. Sometimes it may be negative, but LDH is positive in most of the time, while HCG is positive in choriocarcinoma, mixed tumor, and sometimes in dysgerminoma, while AFP remains positive in yolk sac tumor, embryonal tumor and mixed tumor. Why I am repeating it? Because to inculcate the idea of tumor marker in you people's mind. So when we see a tumor macroscopically, or a gross examination of a tumor is done, even intraoperatively if we see, usually the tumors remains average diameter of 15 centimeter, while dysgerminomas are fleshy, grey, tan or white. Yolk sac tumor is tan or white with a small or large cyst and foci of hemorrhage and necrosis is there. Immature teratoma is white or tan with cyst, and sometimes they have hard cartilaginous or bony focus. Choriocarcinomas, they appear as tissue of hemorrhages and necrosis, and usually they are unilateral. Gestational, these germ cell tumors are unilateral one, but sometimes they may be bilateral in dysgerminoma. So how this patient presents to us with germ cell tumors? In women, we see epithelial ovarian carcinoma, which are slow growing tumors, but the germ cell tumors are rapidly growing tumors. So patient may present to us with subacute pelvic pain because of the capsular distension, because of the hemorrhage within the tumor, because of the necrosis. And because of the rapidly enlarging large tumor of average 15 centimeter, it puts pressure over the nearby organs, that is bladder and rectum, and patient may present with these symptoms also to us, and sometimes menstrual irregularities may be there. Acute symptoms are associated with torsion, as in case of the teratomas, and sometimes rupture can also occur. So what we have to see, first of all, is age is a very important factor in germ cell tumor. Patient with germ cell tumor, whether she is premenarchal or postmenarchal, it is the first point which we have to note. Then we have to see whether the lesion is solid or a combination of solid and cystic, and then radiological imaging investigation should be carried out, which may point that this may be a neoplasm, which is probable neoplasm is there, and a malignancy is possible. Then we have to look for the staging, higher stage of the disease, by looking at the whether ascites is present, whether any pleural effusion is present, or organomegaly is present. So these are the signs which we have to elicit. Now to reach to the diagnosis, important thing is adnexal mass, if it is of 2 centimeter or more in premenarchal girls, or complex mass 8 centimeter or more in premenopausal or reproductive age group or postmenarchal girl, patient usually requires surgical exploration. So if a girl is premenarchal, that is of 4, 5, 6, 7, 8 year, and she is having a 2 centimeter mass, or postmenarchal girl who is having a 8 centimeter mass with which is complex, maybe solid cystic, both of these girls, these cases require surgical exploration. So in young patient, preoperative, in all the patient we carry out all these investigation, but it is of much importance when we talk of germ cell tumor. We need to carry out the tumor markers, serum HCG, AFP, LDH and CA125 level, because it can be a case of epithelial ovarian cancer also. That too we have to exclude. And a radiograph is a must before taking the patient for surgery to exclude the metastasis to the lungs or mediastinum. And the most important thing which, is here, in premenarchal girl, a karyotype should ideally be obtained preoperatively on all premenarchal girls because of the propensity of these tumors to arise in dysgenetic gonads. So the gonad which we are thinking is ovary may not be ovary. So a karyotype is must in premenarchal girls. So now our evaluation also includes the imaging modalities in which the age of the patient is taken, tumor markers are taken, and the imaging results are taken. So in a premenarchal girl, if mass is less than 2 centimeter or with positive markers, then a karyotype is ordered and patient is taken for surgery. While if tumor markers are done and the age of the woman, the girl is postmenarchal girl is there, size is cystic on imaging modality less than 8 centimeter and tumor markers are negative, then this patient can be kept on hormonal suppression for 2 months and then re-evaluated after 2 months. If a postmenarchal girl mass is cystic or maybe solid, suspicion of malignancy is there and positive tumor markers are there, such patient should be straight taken for surgical exploration. So this is how we will proceed with age, with tumor markers, with imaging modalities to plan the management of this patient. Whenever we thought of surgery in these germ cell tumors, fertility has been discussed, the issue of fertility. If fertility is desired, then fertility sparing surgery and comprehensive surgery should be planned. Fertility sparing surgery means that we have to remove the mass and we have to leave the uterus and the contralateral tube and ovary. If fertility is not desired, then we can do the complete staging surgery. As far as staging of ovarian carcinoma is concerned, stage 8 diagnosis, if in case of the dysgerminoma, in yolk sac tumor and immature teratomas, it is seen that the patient presents, 66% of the patient presents in stage 1, with yolk sac tumor 50% patient comes to us, and with immature teratoma 72% patient comes to us. So if a patient comes to us in stage 1, then the chances of survival with proper management is 99%. And with yolk sac tumor it is 95%, with immature teratomas it is 98%. But if the stage increases, stage 2 or stage 4 is there, then the survival chances get reduced. In dysgerminoma, because we are discussing it is separate because it is the most common malignant germ cell tumor, and it's responsible for 30 to 40% cases of all ovarian cancer of germ cell origin. They represent only 1 to 3% of all ovarian cancer, but in case of the germ cell tumors, it is responsible for 30 to 40% cases. 75% cases occur in the age between 10 and 30 years. And the commonest ovarian malignancy which is associated with pregnancy is dysgerminoma. Usually unilateral solid ovarian masses are the tumor markers LDL, PLAP positive and sometimes beta HCG positive. Histological picture shows uniform cells separated by fibrous septa, excellent prognosis for which we are concerned, and they are highly radiosensitive and chemosensitive. This is one of the pic of the dysgerminoma of the ovary, where you can see a solid tumor in the center. You can very well appreciate the cystic appearance with hemorrhagic areas. So treatment of early dysgerminoma is primarily surgical, including resection of the primary lesion and limited surgical staging. Limited surgical staging because they are highly chemosensitive tumor. So the ovarian staging which we perform for epithelial ovarian cancer is not required here. Limited surgical staging includes washings taken from the pouch of the Douglas, from the paracolic gutter, omental biopsy is done. Then the retroperitoneal surfaces are palpated. If any biopsy is needed, it is carried out, and then chemotherapy is administered in patients with metastatic diseases. So minimum operation is ovarian germinoma is unilateral oophorectomy. If there is desire to preserve fertility, as usually the case, which in the contralateral ovary, fallopian tube and the uterus is left in situ, even in presence of metastatic disease, because of the sensitivity of the tumor to chemotherapy. If fertility preservation is not required, then staging with total abdominal hysterectomy and bilateral salpingo oophorectomy can be done. One more important point is here, which I want to emphasize, that in patients whose karyotype contains a Y chromosome, because we have carried out karyotype in perimenarchal girl, both ovaries should be removed, or the uterus may be left in situ for possible future embryo transfer. Because 5% of the dysgerminomas, they occur in phenotype females with abnormal gonads, and if there is a Y chromosome, then the contralateral ovary should be removed. Chemotherapy is the treatment of choice for the following surgery, and the commonest chemotherapy regime which is mentioned in the textbook and in use is the bleomycin, etoposide and cisplatin, which can be used. Radiation loss of is associated with loss of fertility, and secondary malignancy is important late effect of radiation therapy. So it is no longer used for primary treatment. These dysgerminomas are very sensitive to radiation therapy also, and dose of 2500 to 3500 cGaRs is curative, but we do not use it as a primary treatment. It can be used for recurrence, local recurrence if it is occurring, then radiotherapy can be used. Then there are other tumors where the plan of management is similar, that is immature teratoma. But immature teratoma is the important thing is the grading system which we use is the presence of the immature neural tissues because it decides the prognosis of the tumor, along with the tumor markers alpha fetoprotein and HCG. Alpha fetoprotein may remain positive while HCG remains negative. Again, the surgical plan is similar to the dysgerminomas. Then coming to the mature cystic teratoma, that is dermoid. This is the commonest tumor which we get in our day-to-day surgical practice, where we get hair, teeth, sebaceous material in the tumor, and complication, patient presents with torsion, sometimes rupture, and it is managed very well with the by the surgery by performing cystectomy. Then there are other tumors also, endodermal sinus tumor. Treatment is similar, that is the plan of the surgery, and then chemotherapy. In rare germ cell tumors of the ovary, that is embryonal carcinoma of the ovary is an extremely rare tumor. Patients are very young, that is of 4 and 28 years. The patient exhibiting symptoms and signs of precocious pseudopuberty or irregular bleeding may be there. In choriocarcinoma of the ovary is a very rarest tumor, but when it is diagnosed, already the parenchyma of the tissue is involved. So choriocarcinoma of the ovary is always treated as a high-risk tumor, and it is managed, and treatment is followed by the levels of the HCG. Overall prognosis is excellent. Stage 1 disease survival is very good in gestational cell tumor, germ cell tumor. Chemotherapy dramatically improve the outcomes, and that's why we need to discuss, already been discussed in the panel discussion, long-term fertility preservation is achievable in these patients. So we should focus on this in management of the germ cell tumor, but surveillance is required for years, year 1, 2, 3, 4 and at least 5 years by physical examination, serum tumor markers and the radiographic imaging. So take home message for germ cell tumor is it requires multidisciplinary treatment. It needs the gray area, the vacuums in the management needs to be addressed well. Germ cell tumor diagnosis, management and follow-up is required for years, and it's an essential component for that particular patient. Tumor marker, staging and the menarchal status are important determinants in management of these cases, and fertility issue needs to be addressed well. Thank you. Thanks a lot for giving me time, for listening me.
I'll request Dr. Shalini ma'am to also join us for the group picture. Well, I know it is way past lunchtime, but I'll request the patience of the audience for just a little more while as we conduct the inauguration ceremony of our conference. Well, a very good afternoon to all of you. What an honor it is to be addressing this august gathering of academic stalwarts, senior physicians, and dear students. This amalgamation of so many doctors across multiple specialities with a singular focus of enhancing care of children suffering from cancer or other hematological disorder can only have been possible by the will of the mighty God. To spread the light of knowledge and seek the blessings of Ma Saraswati, I'll request the dignitaries, our patrons, Dr. Ashok Gaur, Dr. Dinesh Purani sir, Dr. R.K.S. Dhakar sir, Dr. Harish sir, Dr. Patro, Dr. V.K. Sharma, Dr. Anil, Dr. Vijay to please come forward for the lamp lighting. Been said long back by our pillars of strength, Nana Nani and Raju Mama. I'll also request the dignitaries to extend a floral tribute to late Sri Rajiv Sahai ji, late Srimati Kamla Sahai ji, and late Sri Sheetla Sahai ji. After seeking the benediction of Goddess Saraswati, the guidance of our ancestors, it is time now to move ahead by expressing our pride in our nation. I'll request the dignitaries on the dais and our esteemed guests in the hall to please stand up for Vande Mataram. To please resume your seats. I hope that very soon we learn the entire lyrics to the song and we can hum along. Well, till then, so we are indeed privileged to have with us this assembly of eminent personalities who are revolutionizing healthcare and health education. To extend our gratitude, I'll request Dr. B.R. Srivastava sir to please extend a floral welcome to our chief guest, Dr. R.K.S. Thakur sir. A big round of applause for the floral welcome of our guest. I'll request Dr. Anjula Jain ma'am to please come on the stage and extend a floral welcome to our esteemed patron, Dr. Ajay Gaur sir. A big round of applause for our esteemed patron. I'll request Dr. Sabah Ahmed ma'am to please come on the stage and extend a floral welcome to our beloved doctor and teacher, Dr. Burani sir. A big round of applause for the welcome of our patron. I'll invite on stage Dr. Pankaj Kandotra sir to welcome Dr. Ishan Patro sir, representing National Academy of Medical Sciences. He has served as former Vice Chancellor at Ravenshaw University, Cuttack, is the immediate past president of Indian Academy of Neurosciences. Among his various achievements, a big round of applause to welcome our guest. Now I'll request Dr. Rajni ma'am to please come on the stage and extend a floral welcome to Dr. Harish Gupta sir, Deputy CEO CanKids India, who has more than 25 years of experience in public health, hospital administration and project development. Thank you sir for coming today and for all the help you extend to the institute. I'll request Dr. R.K. Jain sir to please come on the stage and extend a floral welcome to Dr. V.K. Sharma sir, President Gwalior Academy of Pediatrics, who has been most supportive in the successful execution of this CME. A big round of applause, ladies. We are fortunate to have gathered this constellation of luminaries, leading experts from the field for today's CME. This conclave of academicians would have been impossible less the support of a director, Dr. B.R. Srivastava sir, who is constantly pushing us to pursue excellence, be it in academics, research, hospitality, or caring for our patients with empathy and sympathy. I'll request him to please come on the mic and share his words of wisdom in this august gathering.
आज के इस भव्य साइंटिफिक प्रोग्राम में मुख्य अतिथि के रूप में पधारे हुए मेरे प्रिय अनुज डॉक्टर R.K.S. धाकड़, विशिष्ट अतिथि के रूप में उपस्थित डॉक्टर दिनेश भूरानी, जो कि इस अंचल से आज राजधानी में इस अंचल का नाम पूरे देश में रोशन कर रहे हैं। डॉक्टर ईशान पात्रो, फॉर्मर वाइस चांसलर एंड renowned साइंटिस्ट, डॉक्टर दिनेश जी, विजय चौधरी जी, इस कार्यक्रम के पैटर्न डॉक्टर अजय गौड़, नाम बाद में इसलिए लिया कि ये जवाहर कॉलोनी मेरे पड़ोसी हैं और रोज़ हम एक दूसरे को चाय पीते हुए देखते रहते हैं। मेरे छोटे भाई हैं, मेरे स्टूडेंट भी हैं। डॉक्टर V.K. शर्मा, डॉक्टर अनिल शर्मा, सभागृह में उपस्थित इंडियन मेडिकल एसोसिएशन के पूर्व अध्यक्ष डॉक्टर राहुल सप्रा जी और देश के विभिन्न भागों से पधारे हुए अति विशिष्ट साइंटिस्ट, डॉक्टर्स और सभागृह में उपस्थित प्रेस एवं प्रिंट मीडिया, इलेक्ट्रॉनिक मीडिया के सभी सम्मानित सदस्यों, अतिथियों, प्रिय छात्र एवं छात्राओं, देवी और सज्जनों, निश्चित रूप से कैंसर चिकित्सालय एवं संस्थान में स्थापित इस शीतला सहाय सभागृह में यह जो आयोजन किया जा रहा है, उसके लिए मैं आपका स्वागत बंदन किन शब्दों में करूं, यह मैं सोच नहीं पा रहा हूं। ट्रेडिशनली जो मेरे मुंह से दो पंक्तियां निकलती हैं, उन्हीं से मैं आपका स्वागत करता हूं कि स्वागत ही है शब्द यहाँ जो बोला जा सकता है, इसमें छिपा सम्मान भाव नहीं तोला जा सकता है, फूलों जैसे कोमल शब्द नहीं हो सकते, फूलों जैसे कोमल शब्द नहीं हो सकते, किंतु स्वरों का कंपन समझा तो जा सकता है। आप सभी का स्वागत है, वंदन है, अभिनंदन है। साथियों, ये समारोह इस सभागृह में आयोजित जो किया गया है, यह इसलिए भी विशिष्ट है कि दिस CME इज ऑन पीडियाट्रिक कैंसर। ये जो बीच में आप फोटो देख रहे हैं, स्वर्गीय श्री राजीव सहाय का, we now we count pediatric age from 0 to 19 years. At the age of 15 years, when he was 15 years, he developed osteosarcoma. उस वक्त कैंसर के ट्रीटमेंट की, इलाज की सुविधाएं इस क्षेत्र में नहीं थी, तो स्वर्गीय शीतला सहाय जी को उनके इलाज के लिए टाटा मेमोरियल हॉस्पिटल जाना पड़ा और दुर्भाग्य से उनके प्राणों की रक्षा नहीं हो सकी। दुखी माता पिता, जैसा कि हम सुबह से डिस्कस कर रहे हैं कि पीडियाट्रिक कैंसर इज़ डिफरेंट फ्रॉम अदर कैंसर इन द सेंस कि यहाँ एक 4 साल के बच्चे को, 5 साल के बच्चे को जब कैंसर होता है तो हम सिर्फ इस बात की चिंता नहीं करते कि उसकी बीमारी ठीक हो जाए, बल्कि इस बात की भी चिंता करते हैं कि उसका भविष्य सुरक्षित रहे, उसके आने वाले जीवन में उसको किसी तरह की इन्फीरियरिटी महसूस नहीं हो। यह एक अत्यंत महत्व का विषय है। साथियों, स्वर्गीय श्री शीतला सहाय दंपत्ति के इकलौते पुत्र की कैंसर से मृत्यु हुई 15 इयर्स की एज में। माता पिता का दुख का आप अंदाज लगा सकते हैं, लेकिन जैसा कहते हैं कि सच है विपत्ति जब आती है तो कायर को दहलाती है, सूरमा नहीं विचलित होते, क्षण एक नहीं धीरज खोते, कांटों में राह बनाते हैं, विघ्नों को गले लगाते हैं। और श्री शीतला सहाय जी ने एक संकल्प लिया कि इस क्षेत्र में कैंसर चिकित्सालय की स्थापना की जाए। जगह की कमी थी, सरकार ने मदद की, एंड दिस हिल, पहाड़ी, जहाँ पहाड़ थे, उनका चयन किया गया। इकबाल ने लिखा है, नहीं तेरा नसीमन खुसरो सुल्तानी की गुंबद पर, नहीं तेरा नसीमन खुसरो सुल्तानी की गुंबद पर, तू साहीन है बसेरा कर चट्टानों पर, पहाड़ों पर। यू आर एन ईगल, यू शुड रोस्ट ऑन द रॉक्स एंड माउंटेन्स, नॉट ऑन द इम्पीरियल पैलेस। और इस पहाड़ी का कैंसर चिकित्सालय के लिए चयन किया गया। जहाँ पानी की एक बूंद नहीं थी, वहाँ आज इलाज रूपी अमृत की धारा बह रही है और हजारों लाखों लोगों को इलाज का लाभ मिल रहा है। बहुत महत्वपूर्ण विषय पर आयोजित इस CME में हमें हर्ष इस बात का है कि देश के अत्यंत जाने माने विशिष्ट डॉक्टर्स जो कि इस फील्ड में अपना पूरा जीवन समर्पित करके कार्य कर रहे हैं, वह आज इस CME में पधारे हैं। यह इस बात की प्रमाणिकता है कि पीडियाट्रिक कैंसर पर आयोजित इस साइंटिफिक प्रोग्राम का कितना महत्व है। और बहुत सारे डिस्कशंस हुए, आई विल नॉट टेक मच टाइम, लेकिन सिर्फ इतना कहना चाहता हूँ कि यह CME पीडियाट्रिक कैंसर के लिए, पीडियाट्रिक एज ग्रुप के मरीजों के लिए एक नई दिशा इस क्षेत्र में प्रदान करेगा। मैं डॉक्टर भूरानी साहब से बात कर रहा था तो उन्होंने कहा कि इतने सारे पार्टिसिपेंट्स हैं, ये देख के बहुत अच्छा लग रहा है। मैंने कहा सर आप आए हैं तो लोगों को अगली साल भी उम्मीद रही कि जितने गेस्ट स्पीकर राजीव गांधी कैंसर हॉस्पिटल एंड ऑल डिफरेंट प्लेसेस से आए हैं तो हो सकता है कि अगली साल आपको इससे, ये पीछे पर्दा लगाया हुआ है कर्टेन, इसकी जो सीटिंग कैपेसिटी है वो 300 है, 350 के करीब 250 कर दी है। मुझे लगता है कि 100 की कैपेसिटी और अगली कॉन्फ्रेंस में बढ़ानी पड़ेगी जिससे कि ज़्यादा से ज़्यादा डॉक्टर्स इस CME का लाभ उठा सकें। मैं आप सभी का स्वागत करता हूं, अभिनंदन करता हूं, वंदन करता हूं। और डॉक्टर गुंजन ने वैसे मुझसे घर पे तो कहा था कि आपको स्वागत भाषण देना है और यहाँ अनाउंस किया कि वर्ड ऑफ विजडम बोलना है। तो वर्ड ऑफ विजडम में क्या बोलूँ, एक ही चीज़ कहना चाहूँगा कि एनी नॉलेज, एजुकेशन which we acquired, once it is used for the welfare of the society, then it is wisdom. Acquiring knowledge is not enough until unless we use this knowledge for the welfare of the society. It's just only knowledge, no wisdom. So word of wisdom for today is that whatever we learn here, let us apply that knowledge for the welfare of the society. Then really our aim will be successful and goal for organizing this CME will be successful. Thank you very much for your time.
Thank you, sir, for those wonderful words. We are happy to share that today's CME on pediatric oncology and hematology is being attended by more than 100 delegates. We have had quality abstracts for paper and poster presentation, and we are eagerly looking forward to the quiz that is about to happen in the coming hours. This, along with a pantheon of more than 50 experts from across the country, has happened thanks to the support and guidance of our patrons. Our first patron, Dr. Ajay Gaur sir, is a household name in Gwalior city. He has touched many an innocent lives and set the foundations for healthy life for lakhs of children, if I'm not wrong. A clinician par excellence, he is also a stellar academician who has held multiple research projects, held many eminent posts through his illustrious career, and has been most generous in his support for this CME. I'll request sir to please come on the mic and address the gathering.
Thank you, Dr. Gunjan, and good afternoon to all. I will not take too much of your time. मेरे आदरणीय डॉक्टर BR सर, मेरे टीचर, और जैसा सर ने कहा मैं हमेशा सर को एक बड़े भाई के रूप में देखता हूँ और वो मुझे उसी तरह जो है वो मेरे करियर में जो है वो गाइड करते हैं। मेरे दो बड़े पुराने डॉक्टर दिनेश, मैं जब रायपुर में AP था तब दिनेश PG कर रहा था, तो हम लोग साथ साथ रायपुर का ट्रैवल करते थे, यहाँ से रायपुर और रायपुर से ग्वालियर। तो तब से हमारी दिनेश के साथ जो है वो दोस्ती है। और डॉक्टर धाकड़, अवर डायनेमिक डीन, he is very innovative in academics and all the dignitaries. I just met Dr. Harish for the first time, very genuine person. Dr. Patro, I know him since long when he was in professor of zoology in the J University, as my father was also professor of zoology in Jivaji University. And Dr. Anil, Dr. VK, all my dear friends and students. And जैसा कि डॉक्टर गुंजन ने बोला इस एसोसिएशन के लिए, and we have so many cancer patients in our pediatric department, but unfortunately we don't have the registry system, we don't have the licensing with other institute, as well as we don't have anyone who can hold the hand of the diseased as well as their family. So we are just discussing with Dr. Harish and with our dean also, and we are thinking we have lot of practitioners also of pediatrics here. Dr. VK is president, VK Sharma is president of GAP, Dr. Rahul, Dr. Gopi, all are sitting here. So we should, Dr. Banga sir, so we should have I think one system in the Gwalior, so that at least the patient who is suffering with this can have something, so that we can assure him, we can counsel him, we can show him some path, so that he will not go here and there. And as you know that these pediatric cancers are very unique in their diagnosis, and early diagnosis and early management is the crux of this. Thank you very much, sir, for inviting me here, and thank you very much. Good day.
Thank you, sir. We are indeed too elated to have with us Dr. Dinesh Purani, sir, Director, Department of Hematology and Bone Marrow Transplantation, RGCI, Delhi. His immense knowledge, vast experience, his gentle tone and his calm demeanor are exemplary and set a benchmark for us to aspire for. Even though his education at work has taken him across the globe, he has still remained deeply rooted to the city of Gwalior. His mentorship guides us and strengthens our confidence. I'll invite Dr. Dinesh Purani, sir, to please come on the mic and address the gathering.
आज गुंजन खाना खाने नहीं देगी किसी को भी, लग नहीं रहा है कि हम लोग खाना खाएंगे. डॉक्टर श्रीवास्तव ने जब यहाँ स्टार्ट किया था, there was no cancer activities here. Imagine the many years back. Now we are sitting with the pediatric specific conference with so many people attending it. So I really congratulate Dr. Srivastav, Dr. Gunjan and his whole team that we have reached to the level that in Gwalior city we are able to do a specific focused CMAs, and we are going to do it regularly. I'm the only person who is practicing outside and is still the part of that 6 photos or 8 photos are there. So I'm really thankful. I feel honored that I'm the part of the same. I've been considered as a part of the city, and I'm really thankful for this. I congratulate everyone and thank you for inviting me.
Thank you, sir. Well, we are immensely proud to have with us our dashing and dynamic Dean, sir. Not only a great surgeon, he shines as a teacher and a leader of even greater credence. Under his leadership, GRMC Gwalior has seen monumental transformation with drastic developments in hospital, enhanced patient care, advanced training for students, and initiation of landmark clinical projects like registry. सुनकर कर दे अनसुना, ऐसी इनकी आवाज़ नहीं, मिलकर भूल जाए कोई, ऐसे इनके अल्फाज नहीं, किसी महफिल में छुप जाए, ऐसे इनके अंदाज नहीं, सूरज से दमकते हैं ये, किसी परिचय के मोहताज नहीं. Ladies and gentlemen, a big round of applause. I'll invite Dean, sir, to please come on the mic and address the gathering.
Thank you, Gunjan, for your words, and I can say proudly, she is a bright future of this Cancer Hospital and Research Institute. B.R. श्रीवास्तव सर, वो अनुज कह दिए तो मेरे बड़े भाई हैं ही, पहले से हैं, उनसे बहुत कुछ सीख रहा हूँ. दिनेश बुरानी सर का साथ छात्रावास से लेके और उनके दतिया वाले घर से लेके और अभी तक वैसा का वैसा आशीर्वाद बना हुआ है. डॉक्टर अजय गौड़ सर हमारे मेडिकल कॉलेज के एक टीचिंग और रिसर्च के बहुत बड़े पिलर हैं. अभी एक हिस्टोरिकल फर्स्ट टाइम रिसर्च मेथोडोलॉजी फॉर फर्स्ट ईयर पीजीज, अभी वो एक डॉक्टर बृंदा जोशी और वो दोनों फर्स्ट टाइम वी स्टार्टेड इन आवर मेडिकल कॉलेज. डॉक्टर आई डोंट नो अबाउट फर्स्ट टाइम आई मीटिंग डॉक्टर हर्ष, डॉक्टर चौधरी and Dr. Patro, Dr. VK, Dr. Ajay, and all ladies and gentlemen. Research, especially for the clinicians, is always an integral part. As I came to know, you are talking on pediatric cancer. बड़ा ही एक किसी के सर ने एक जो बहुत ही एक ऐसी घटना जिसकी वजह से हम यहाँ बैठे हैं। हम लोग कई बार देखते हैं कि एक छोटा सा बच्चा जिसने अपने जीवन का कुछ नहीं देखा और वहाँ पर पता चलता है कि उसको इस तरह का कोई बीमारी है। बुरानी सर चूँकि उसी सेगमेंट में काम कर रहे हैं और यहाँ से ऑस्ट्रेलिया जाके और वहाँ से लेके जो इंडिया में अभी राजीव गांधी कैंसर इंस्टीट्यूट में ही इज़ टोटली डिवोटेड टू द पीडियाट्रिक कैंसर। ही डिड लॉट ऑफ बोन मैरो ट्रांसप्लांट्स एंड ही इज सेविंग लॉट ऑफ लाइफ्स ऑफ द किड्स। बट कभी कभी जो एक भविष्य सा दिखता है और एक ही क्षण में पता चलता है कि वो भविष्य अंधकार में है। कभी किसी के बस में ये चीज़ें नहीं होती कि उसे वापस लाया जा सके। बट मैं कह सकता हूँ कि अभी हम उस रिसर्च के टाइम में हैं जहाँ अर्ली डिटेक्शन एंड आई थिंक टारगेट थेरेपी, जीन थेरेपी, बहुत सारी चीज़ें हम रिसर्च के माध्यम से जल्दी डायग्नोस कर रहे हैं, उनको ट्रीट भी कर पा रहे हैं। अभी सर मैं बताना चाहूँगा कि कई बहुत सारी चीज़ों को, जैसे जीनोम सीक्वेंसिंग हो गया, मॉलिकुलर जो कैंसर से रिलेटेड कई मॉलिकुलर बायोलॉजी है, HLA टाइपिंग है। मैं आपको बताना चाहूँगा बुरानी सर कि इट इज़ गुड न्यूज़ फॉर ग्वालियर। आई थिंक in the month of June we will start all these investigating tools in our institute very soon। तो रोजाना कहीं ना कहीं चीज़ें बढ़ रही हैं। सरकार भी, जो मैं देख रहा हूँ पिछले 10 साल से, जितना हेल्थ और मेडिकल एजुकेशन पे भारत सरकार और स्टेट गवर्नमेंट ने जितना फोकस किया है वो कभी होता नहीं था। जितना बजट पूरे 8 या 10 मेडिकल कॉलेज का होता था उतना आज एक मेडिकल कॉलेज का है। और सारी सुविधाएं सरकार उपलब्ध करा रही है, जिसमें कभी कभी तो 60-40 के रेशो में, जो 60% सेंट्रल गवर्नमेंट कर रहा है और 40% स्टेट गवर्नमेंट कंट्रीब्यूट कर रहा है। एक और चीज़ बताना चाहूँगा कैंसर से रिलेटेड, हमारा टर्सरी केयर सेंटर जो काफ़ी दिनों से चल रहा था सर, एंड सून वी विल गेट, they are on board, they are in the SIP, new brachy, linear accelerator and CT simulator. All these machines, they will be start within 2-3 months in your city. So this is only possible because of the the vision of the government and because of you guys, because we are forcing government, we are forcing system, just bring it, क्योंकि हमें इसकी आवश्यकता है। जब हम किसी का दरवाज़ा नॉक करते हैं कि नहीं हम ये कर पाएंगे, तो फिर मिलता है, चीज़ें आती हैं और उसका फ़ायदा हमेशा समाज को मिलता है। BR सर का चूँकि बहुत बड़ा योगदान इस क्षेत्र को है, और मैं ये कहना चाहूँगा सर कि कई बार ऐसे कंपैरेटिव होता है कि नहीं ये प्राइवेट है और ये सरकारी है और ये ट्रस्ट है। हम लोग हेल्थ फैसिलिटेटर हैं, वी आर हेल्थ पार्टनर्स। कोई सरकारी और प्राइवेट का कोई भेद किसी लेवल पे नहीं होना चाहिए और ना होगा। और जो इन्वेस्टिगेशंस हम शुरू करने जा रहे हैं, हम आपको भी पूरे शहर के जो जितने क्लिनिशियंस हैं उनको बुला के, और जिन जिन में हम मदद कर सकते हैं, जो भी उसका मान लीजिए एक मिनिमम चार्जेस होंगे, तो उसके साथ भी हम शुरू करने वाले हैं। जो पैट सिटी अगले महीने शुरू, एक और आपने तो शहर में एक अलग सा एक बहुत ही शानदार सा एक पैट सिटी लाके शुरुआत की थी। JRMC में भी सर नेक्स्ट मंथ पैट सिटी विल स्टार्ट एंड इट विल बी एट लो कॉस्ट। सो मैं कह सकता हूँ कि जितने भी CMEs, रिसर्च, इट्स जस्ट फॉर द एक्सचेंज ऑफ नॉलेज, एक्सचेंज ऑफ थॉट्स एंड इंटीग्रेशन ऑफ द नॉलेज इन बिटवीन। तो मुझे उम्मीद है कि हम सब इस तरह की जो कार्यशालाएं हैं उनसे लाभान्वित होंगे और समाज को कुछ न कुछ दे पाएंगे. थैंक यू गुंजन फॉर योर वर्ड्स.
Thank you, sir. Well, the CME has been very special to us for multiple reasons, chief being the enthusiasm of our delegates and the host of illustrious guests. As a token of gratitude, I will now be executing the memento distribution ceremony, for which I'll first request Director Dr. B.R. Srivastav sir to please give a memento to our chief guest Dr. R.K.S. Thakur sir. A big round of applause, ladies and gentlemen. I'll request Dr. Anil Sharma to please give the memento to our patron, Dr. Ajay Gaur sir. A big round of applause, ladies and gentlemen. I'll request Dr. Vijay to please give the memento to our patron, Dr. Bhurani sir. I'll request Dr. V.K. Sharma sir to please give the memento to Dr. Patro sir. We are grateful to NAMS for their support in this CME, and thank you, sir, for visiting us. I'll request Dr. Rajput sir to please come on the stage and give the memento to Dr. Harish sir. I'll request Dr. Tripathi sir to please give the memento to Dr. V.K. Sharma sir. A big round of applause. We are grateful for all the support we have received from each and every one. I'll now invite Dr. Anil Sharma sir for a vote of thanks.
Respected Chief Guest, Guest of Honor, Distinguished Chairperson, Eminent Speaker, Faculty Members and Delegates. It is my privilege to propose the vote of thanks on this occasion for the inauguration of our CME on Pediatric Hematology and Oncology. First, I express my sincere gratitude to our extreme dignitary for gracing this occasion and blessing the event successfully. A special thanks to all the department supporting staff who worked sincerely for this. After this inauguration ceremony, lunch will be served. All dignitary delegates are kindly join the lunch. Thank you.
Just one tiny thing. I'll request everyone to stand up for national anthem.
Jai